Hi, my name is Bethany Het-Gauthier, and I'm a biostatistician working in global health. I first became interested in quantifying health issues when I was a Peace Corps volunteer working in Namibia. The region where I was working had an HIV prevalence around 25%. Every day there were visible effects of having such a high infection rate. However, at the time that I lived there in 2000, there was no government response. There was no HIV testing, there was no treatment available. And I remember this sense of helplessness. Folks didn't know how to respond, they didn't know what to do with their own infection or infections in their family. At the time, I went to a presentation, and it was a beautiful presentation full of graphs and figures and numbers. And the person there was talking about what would happen in Namibia if there was no response to the HIV infection, and then what could happen if they addressed it with treatment and testing. And I left the talk feeling very empowered, feeling like we had clear evidence of where we needed to go and what we needed to do in order to improve the problem. So from that point, I walked up to him and I said, "Very interesting talk. What do you do for a living?" And he said, "I'm an epidemiologist." And from that point on, it sealed the deal for me. I knew what I wanted to be when I grew up. I am currently a faculty member at Harvard Medical School. I am an instructor in the Department of Global Health and Social Medicine. Right now, I'm on a leave of absence and am a visiting instructor at the National University of Rwanda School of Public Health. Over the last 10 years, I've continued to work in global health environments. And what it's become very clear to me is our clinicians, our nurses, they're aware that there's issues within their health systems, but they have a hard time mobilizing change around those issues. So the benefit of quantitative sciences in public health is we're able to tell a story of what's really happening and identify solutions of how to address them. I've seen data be used to mobilize change in hospitals, mobilize change in funding mechanisms, and it's really, again, how it relates to my time as a Peace Corps volunteer. It's that sense of empowerment. It's that sense of knowing that you can make a change and being able to measure that change is happening. A real-world example of how we use numbers to facilitate change. I've been working with community health departments in Malawi and Rwanda who are interested in using the data that's routinely collected by community health workers in order to inform funding and inform policy. And one of the challenges that they were facing is that the data routinely collected by the community health workers was of low quality. And we always suspected that the quality was low, but again, being able to make action and make change was difficult to do. In Malawi, they did an assessment using a method called lot quality assurance sampling, a very simple statistical technique in order to quantify the levels of data quality. They identified some areas that were having poor data quality and were able to tailor interventions specifically for those areas to improve the data quality. The good news, after 3 months, we saw an immediate improvement in the quality of data, and we've now gone from data that's full of errors and difficult to use to data that's interpretable and being used to affect change. So part of my role in Rwanda right now is to improve the research capacity of our colleagues there. And one of the challenges that we face is there's a huge interest in research, but not enough hands on the ground to support the training and capacity building of researchers in country. So I'm really excited about this program as an opportunity to train our staff and our colleagues in order to have better skills and better resources to measure the change that they want to measure. This is an example of how we've been able to affect change in our community health worker program in Malawi. If you look at the graph from January to May, we were getting information on the percentage of women who were pregnant who did not have an HIV test and did not have an ANC visit. ANC is antenatal care, so it's getting care during your pregnancy to ensure that your baby is developing correctly and you'll have a healthier delivery. And as you can see, the ranges of the data reported were all over the place, including oftentimes in areas that were not even possible. More than 100% of pregnant women had not been tested for HIV. It just didn't make any sense. So then we did our data quality intervention where we assessed data quality and then targeted areas with poor data quality for improvement. And you can see after 3 months, we were able to get data that was within plausible ranges and made a lot more sense. And this data is now being used to affect program change. So we used a technique called lot quality assurance sampling that was able to identify areas with good data quality and poor data quality. We followed up that assessment with interviews where areas with poor data quality were, those community health workers were interviewed, and we asked them what were their challenges to getting good data quality. Their feedback were things from the forms were complicated to fill out, they were not in the local language, so it's difficult to understand what exactly was being asked to be reported. So we made a lot of changes to the forms based on those results. In the areas that had good data quality, we interviewed those community health workers, and they provided feedback that they had actually shifted the task of data collection and data aggregation from community health workers to a higher level staff member, and they found that the shifting of the responsibilities led to better data quality. So implementing those interventions combined is what we believe led to better data quality.